Okay, let's start then. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. It's a pleasure to be talking to you today about this very thorny topic. And I want to warn the audience that this is the date of my presentation, June 24. Things may change tomorrow, so the half-life of my presentation is very short. In fact, I've presented this topic yesterday, and I've changed many slides in my presentation today. So this is a very evolving field. Before I start, I would like to thank you all, specifically, our heroes, residents, and fellows who are the frontliners treating our patients. And also, I'd like to acknowledge the relentless contribution of our scientific committee, who is working day and night to review the latest evidence and update our treatment protocols. So I'll be taking you through a journey for this pandemic from the bench to the bedside. So this is the unseen enemy, the SARS-CoV-2 virus, the new plague. Sorry, can I remove this? Can you see this on the screen?
What is it, sir?
Like these messages I'm getting, or you're only seeing my PowerPoint presentation?
No, we're seeing your
okay, great.
PowerPoint.
So this is a virus. It's an RNA envelope virus. The S spike that you see here and on this electron micrographs is important for cell entry. This is an infected alveolar cell full with multiple virions are ready to burst and infect many other cells. Unfortunately, this has never happened before, that we've been flooded with the literature on a daily basis. It's been estimated that around 23,000 papers have been published to date, and this number is doubling every 20 days. So it's among the biggest explosions of scientific literature ever we've seen. This has created a huge pressure on us to keep up with the evolving evidence and treating our patients. I would like to ask all attendees to turn off their microphones, please. As of June 22nd, there are on clinicaltrials.gov more than 2,000 ongoing trials. Certainly not all of them are of high standards, but these are registered trials on clinicaltrials.gov. If you look at the weekly publication on Medline for the peer-reviewed publications, this is starting in February and moving on to the third week of June. And this is each bar represent a weekly number of publications, and you can see a huge surge of the number of publications over time since February until June. And if you look specifically at COVID-19, the treatment publications as of June 22nd, we have 5,023 publications only for treatment therapeutics. Journals have done their best to squeeze the peer review process. Before the pandemic, it used to take in good journals up to 3 months to between submission and publication on a pre or early publication on their websites. During the pandemic, many journals have squeezed this timeline to reach less than 2 months. But despite this, journals are now overwhelmed. This is a snapshot of the Lancet submission website, and you can see they put a disclaimer there that they are receiving unprecedented numbers of COVID-related submissions, and they are distributing all the submissions between all editors of the Lancet family journals. So this includes many Lancet journals: Lancet Medicine, Lancet ID, Lancet Oncology, Respiratory Medicine, etc. Even the peer reviewers are under significant pressure. This is an example of a paper I've received in mid-May for the May proceedings, and they asked me to send my review to them for a COVID submission within a week of the date I received the email. So I accepted this invitation. I reviewed for them within 5 days. I also have a paper under review by them. It's taken more than 1 month. And this is the editorial assistant email to me that they are experiencing an overwhelming number of submissions and they can't find enough peer reviewers to review our papers. So this has led investigators and researchers to post their findings on the preprint servers. And as you can see on a daily basis on your social media groups, that people are sharing papers and PDF versions, and you can see med archives or this one, med archive listed on these publications. This is a preprint server that as of 2 days ago, it has more than 5,000 preprint publication. So before we talk about the management of these patients, we really need to understand the intricacies of how this virus enters our system, what does it do, and what are the treatment options that we have. As you've seen initially, the S spike is on the virus is important to attach to a well-known receptor on our cells, and this is called the angiotensin converting 2 enzyme receptor on human cells. And this is receptor is mainly present on type 2 alveolar cells, which represent around 80% of all human expressing cells of ACE2 receptor. It's also present on the nasal mucosa and the upper respiratory tract, on the endothelium, the heart, the kidneys, intestines, and more recently we know that it's present also in the pancreas and the CNS tissue. So this is why the virus has tropism for multiple organs in our system. This is an illustration of how the virus infects and replicates inside our cells. So after attaching here to the ACE2 receptor with the help of the CD147 and TMPRSS2 receptors, it enters our cell, and the viral genome is released, and it goes through this manufacturing process. And each phase of this replication is a target of antiviral therapy that we're going to be talking about. So this is a cellular view of what happens after a virus infects the alveolar cells. So it attaches to these receptors, the ACE2 and TMPRSS2 priming. It enters the cell, gets replicated, and you have multiple virions generated, but at the same time, it does a lot of collateral damage. So it causes first the cell to go through a procedure through pyroptosis, which is an apoptosis with inflammation. Pyro stands for pyrexia or inflammation. So while it's replicating inside these cells, it generates a lot of cytokines and collateral damage. So it induces the interferon type 1 response, which is very important at the early phase of viral replication. And through multiple feedback loops, it interacts with the T cells, the macrophages, and the monocytes. And this will lead to one of 2 scenarios. The normal scenario, which is the healthy immune response, these viruses that gets neutralized by antibodies, and these antibody complexes with the virus get phagocytized by the alveolar macrophages. Also, the CD8 T cells recognizes and help in the elimination of these infected cells. And so the virus is inactivated and its infected cells are rapidly cleared, and there would be minimal inflammation and lung damage, and the virus would be well contained. This is opposed to the dysfunctional immune response, where instead of containing the virus will replicate quickly. There is excessive infiltration of monocytes, T cells, and macrophages in the tissue, and a release of different cytokines, unchecked release of cytokines, destruction of the intracellular junctions, leading to pulmonary edema and widespread inflammation and multi-organ damage. If you zoom out from the cellular level to the macrocellular level, this is the alveolar space, where the endothelial cells, the pericytes, and the inflammatory cells, they act hand in hand to preserve vascular integrity. They have an anti-inflammatory role, they have an anticoagulation role. With this cytokine release, and the recruitment of all these inflammatory cells to this infected area, you have dysregulation of all this defense mechanism. So you have vascular leakage leading to acute lung injury, pulmonary edema. You have disruption of coagulation cascade leading to thrombosis, and you have massive inflammation leading to the IC and pneumonia and lung injury. So there are multiple molecular phases of this infection. And so after the virus enters the cell, as I've explained, the immune response system and the first cytokine wave is so critical to contain the virus. At the early phase of infection, you have an early and robust type 1 interferon. And it's multiple cytokines that act together to contain the virus and suppress its replication and spread. So it promotes the intracellular RNA degradation, the virus clearance, and at the same time, it contains the collateral damage of the inflammation, so it induces tissue repair, and it triggers a prolonged adaptive immune system. So this is the innate immune system leading to a prolonged adaptive immune system response and containment of the virus and developing short-term immunity. Certain people would go into what is called the immunodeficient state instead of a robust interferon 1 response, where there is a delayed type 1 interferon response or a blunted one, which may explain why certain people have more severe disease. So this compromises the control of the virus, so the virus will replicate unchecked. There will be paradoxical hyperinflammation induced by this type 1 interferon. And then certain people, go from this phase to a even more advanced phase called the cytokine storm, or a lethal second wave, where you have a massive increase of different pro-inflammatory cytokines, interleukins, TNF, and many others, leading to a cytokine storm. This will generate, this molecular inflammatory process will generate 3 types of phenotypes for COVID disease. The mild one, or the asymptomatic one, which account for more than 80% of patients who get infected, where patients have either no symptoms or very minor non-specific symptoms who will not progress to a more severe disease. And then you have the moderate type, where they have overt pneumonia, sometimes with hypoxia or without hypoxia, and these patients who require hospitalization can account from 10 to 15%. And you have the unfortunate severe cases who develop systemic hyperinflammation, acute lung injury, or ARDS, and require critical management. And this is where mortality happens in these cases. So how does tissue damage happen? As I've explained, at the early onset of viral replication, you have pyroptosis. So there is massive epithelial and endothelial cell apoptosis, and these patients progress to severe disease. There is vascular leakage, and you have this pro-inflammatory mediator release or the cytokine release. And another mechanism of tissue damage happens through the downregulation of the ACE2 receptor. As I've mentioned earlier, the ACE2 receptor is so critical for this virus entry into the cell. This downregulation of the ACE2 receptor and shedding by the viral S protein will cause a dysfunction in the renin-angiotensin system, which leads to more disruption of the hemodynamics or cardiovascular system, kidney system, and vascular permeability, and leading also to acute lung injury. Another mechanism has to do with infection of the SARS-CoV-2 to the T cells, which play a very important role in viral infection. And usually infection of T cells is abortive, which means it will cause to cell death, but the virus won't replicate inside the cell. It will just lead to cell death. So certain people that fits into the category of severe or critical illness will either have hypercytokinemia or a cytokine storm. Patients who have hypercytokinemia, they have high levels of inflammatory mediators or cytokines, which are generally below the observed levels we see in macrophage activation system, or primary or secondary human phagocytosis syndrome, HLH, or in severe cytokine release syndrome. And you have the cytokine storm, which is associated with very high level of these inflammatory mediators that leads to critical illness such as ARDS, multisystem organ failure, DIC, etc. So there are 2 types of immune dysfunction, observed so far with the COVID-19 disease. One pattern is highly suggestive of a macrophage hyperactivation syndrome, where you have high ferritin, you have an elevated H-score in a quarter of patients, and this is mainly driven by interleukin-1 beta. And as I said, 25% of these patients have high H-score that is used for the diagnosis of the macrophage activation syndrome. And as you can see, these are the parameters: fever, splenomegaly, cytopenias, ferritin height, high triglyceride, fibrinogen, bone marrow findings, ALT, and non-immunosuppression. The other pattern is, immunoparalysis. This is immune dysregulation, which is driven by interleukin-6, which leads to immunoparalysis, as indicated by, global lymphopenia. Lymphopenia in COVID-19 is observed in around 80% of hospitalized patients, and there are multiple mechanisms that could explain the reason for this lymphopenia. One of them is this infection of the T cells and leading to abortive apoptosis. And the other one is related to the cytokine release, which have negative effect on T cells, either by TNF causing more T cell apoptosis, or interleukin-1, which leads to, which prevents T cell proliferation, or type 1 interferon, which recruit the T cells to the infected organs. So in autopsy studies, we observe a lot of patients have accumulation of lymphocytes and monocytes in the affected organs. So the two key point messages here are that the virus induces sequential impairment and hyperactivation of the immune system. So either paralysis of the immune system or hyperactivation of the inflammatory mediators. An early viral clearance by type 1 interferon is the key to preventing further viral replication or T cell exhaustion or the subsequent cytokine storm. And this is so critical, as we're going to see now when we discuss the clinical studies and the bedside management of these patients, is to know the right timing and which patients to give what treatment to. This is so critical. So we also need to understand the dynamics of this viral replication. This is a recent study published in Lancet ID. All these studies mostly are published within the last 2 weeks. And a very important finding of this study, that the virus load, or the viral load, peaks at the beginning of the symptoms as opposed to other respiratory viruses. So you can see here, the peak of the viral load is at the beginning of the patients having onset of symptoms, and it declines over time, whether this is from salivary viral load or tracheal, endotracheal aspirate viral load. So it's highest at the beginning of symptoms and goes down with time. This is another study published this week in Nature Medicine, again looking at a large group of patients. And again, you can see the high viral load is at the onset of symptoms and goes down over time. If you compare this to SARS-CoV-1, which was in 2003, this is the day 0 of onset of symptoms, and the virus would peak later in the disease. So it would peak around 10 days after the onset of symptoms. However, SARS-CoV-2 behaves like influenza, where the peak of the viral load is at the beginning or onset of symptoms. And this is very important for the consideration of antiviral treatment. So this is a summary of what I've tried to explain earlier, that a normal human immune response to the virus is illustrated in this figure. So basically, the virus, viral load will peak early on, and you have a robust type 1 interferon system that will check and control the virus in place. The viral replication will go down, and there will be a minimal surge of inflammatory cytokine that will assist the type 1 interferon response in controlling the virus, minimizing tissue damage, and the patient will have a mild or moderate disease, and they will recover, and the lymphocyte count will recover. As opposed to this subgroup of patients, the smaller subgroup that go into severe disease, where there is either a blunted, you can see here the dashed green line, a blunted type 1 interferon response, or a delayed type 1 interferon response that will leave the virus uncontrolled. So the virus would replicate, and the viral load will be even higher, as has been shown in the viral dynamic studies. And then you will go into an inflammatory cytokine release syndrome, and the patient will go into severe disease, persistent lymphopenia, and the T-cell exhaustion and immune paralysis, and will develop end organ damage. And so this is really important for our treatment management plans. So now to the bedside after this journey at the bench. We'll start with the natural history and the clinical presentation. The incubation period of this infection on median is 4 days. So on the median or average, patient after being exposed to the virus will develop symptoms after 4 days. The majority of patients will develop symptoms by 7 days, and very, very few, less than 5%, will develop symptoms beyond 10 days. So the majority of patients will develop symptoms at 7 days, and the median is 4 days. The estimation of asymptomatic patient is so critical because this affects our estimation of case fatality. We've heard at the beginning of the pandemic that this infection case fatality is anywhere between 3 to 5%, much more than influenza, because at that time we didn't know that the virus could infect people and many patients will go asymptomatic. This is a very nice review of all studies that of representative sample or longitudinal samples of a cohort of patients who were tested systematically looking for asymptomatic patients. And you can see the range of asymptomatic patients who are infected. It's estimated to be on average of 40%. Some studies were even much higher, but we believe that on average it's 40%. So 40% of patients can be asymptomatic. But asymptomatic doesn't mean there is no tissue injury. Very important study was published this week in Nature Medicine by a group of Chinese investigators. And this is so unique that because this study was not a convenience sample, was not a consecutive sample of testing or PCRs. It's through close contacts tracing of COVID patients from February through April in Wanzhou district. So everybody was screened contacts. So it's not a convenience sample, it's contact tracing. And they found out that there was 37 asymptomatic cases in this outbreak that happened in this district. And they admitted all of them, and they screened all of them and did a marvelous study, molecular and imaging and etc. But what's interesting here that in this series, 57% of patients had lung abnormalities on CT. They were completely asymptomatic, but they had CT findings of infiltrates. So there is tissue damage, although patients may be asymptomatic in 57% of the patients. The primary symptoms in general for symptomatic patients, it goes anywhere. The most common were fever and dry cough. Then you have fatigue, chills, nasal congestion, sore throat is common, dyspnea, and GI symptoms and myalgias. But there are also minor symptoms in a minority of patients that ranges from anything like skin ulcers to strokes and MIs, etc. This is data from a large cohort from the UK of 20,000 patients. And you can see that the majority of patients will have cough and fever and shortness of breath. And in terms of comorbidity distribution, many of them have chronic cardiac disease, diabetes, pulmonary disease, and we'll talk about this. Now, what's interesting also about this, that, the clinical presentation varies between patients. And, we've experienced very nice stories. In fact, if you ask a household is infected and you ask them about symptoms, and everyone have different symptoms. If you have the flu at a household, usually everybody has fever, myalgia, they're coughing, they're feeling ill. But, in COVID-19, we've had many of our friends or patients infected as a household, and you ask what symptoms they have. And, some of them would have GI symptoms, others would have fever, others would have anosmia or dysgeusia. And so it's so heterogeneous and variable. And in this study, for example, of 1,400 patients, ENT complaints were more common in young patients, whereas fatigue and fever and loss of appetite, GI symptoms were more common in elderly patients. And men would have more cough and fever, whereas women would have more loss of smell, headache, nasal congestion, and fatigue. If you look at the radiographic and lab abnormalities classified by disease severity, the majority of patients, as I've illustrated, even in non-symptomatic patients had CT abnormalities, but even patients who have mild disease, and 84% have infiltrates on CT. Also, many of them had high inflammatory markers or high LFTs, and lymphopenia was common across all disease severity groups. Now, a very important question for us as treating clinicians is how to assess the disease severity, and are there certain risks that are associated with critical illness or severe illness? And that's very important for us to risk stratify our patients in terms of ICU admissions or admission to the hospital. If you look at the time onset of severe symptoms, it's usually around 1 week, and this fits with our understanding of viral dynamics. So the virus would peak early on, it will lead to tissue damage, and by day 7, it has led to enough tissue damage that patients would present with severe disease in those who have dysregulated immune response. And so this is the time when patients would present with dyspnea, and then after 2 weeks, they will progress to a multi-system organ failure or critical illness requiring ICU admission. And this 1 week is so important. You're going to see later when I discuss the steroids and antiviral therapy. This is consistent with our understanding with the viral dynamics. So around 20 to 30% of hospitalized patients with COVID-19 will develop severe disease or progressive lung damage that will lead to necessitate ICU admission and ICU care, and mainly for pulmonary complications, which are related either to vascular barrier breach because of the inflammation of the alveolar space and pericytes, or because of endothelial inflammation, which has been documented in multiple autopsy studies, DIC, and the hyperinflammatory state. Again, there would be multi-system organ failure in a subgroup of patients, either related to the virus tropism to these organs. So patients may have myocarditis, or they have acute kidney injury, or they have encephalitis, or they have a stroke, or it's related to the cytokine storm leading to multi-system organ failure, or the synergy of both. So it's important to know, to risk stratify our patients. Now, this is one of the disease severity spectrum. There are many out there, and these are arbitrary, I would say these are arbitrary. So there could be certain variability in different guidelines, on how they classify the patient. But what's common among them, we have the asymptomatic group, we have the mild illness group, and then we have the moderate, severe, and critical, which are usually hospitalized. The moderate patients are the ones who have viral pneumonia and see chest X-ray. The severe ones who require oxygen, and the critical illness are those who get intubated or have multi-system organ failure or septic shock. In terms of distribution of the severity of illness, the largest series come from China that saw the early pandemic and have the highest number of patients initially, and studied them more than others. So, you have the majority of patients filled in the mild category. You have around 13.8% of patients severe illness and 4.7 critical illness. And in terms of case fatality rate, you can see those who have critical illness, around 50% of them will ultimately die. Those who are elderly, more than 80 years, 14.8% die, and so on. So different comorbidities have different case fatality rate. This was also illustrated in the cohort in New York outbreak, where the majority of patients, 87%, had at least one comorbidity, and hypertension, obesity, and diabetes were the most common comorbidities. In another study from UK, a large cohort, 20,000 patients, these were the variables associated with the mortality, most importantly age, above 80 years, and chronic diseases, and male gender were associated with higher mortality as opposed to others. Now, if you look specifically at patients who end up being admitted to the ICU, this is a recent study in Lancet that looked only at patients who are admitted to the ICU in New York. And the older the patient, the more likely they're going to die. As you can see here, this dark blue, navy blue bars illustrate the patients who died because of COVID-19. And death occurs at any time after ICU admission. You know, some people die early in the disease. Some people would stay for more than a month and, you know, develop ARDS, multi-system organ failure, and die very late after ICU admission. The same variables again were illustrated. You know, age is a significant player here, chronic diseases, diabetes, and we'll talk briefly why we think these are at high risk. Interleukin-6 and D-dimers, inflammatory markers, are other prognostic factors that, you know, tell us which patient would get very sick. So the question is, you know, can we predict which patients develop critical illness, and would we need to pay attention to these patients? And I think, yes, similar to all other diseases, you know, we know of the CURB-65, the PSI score, the Apache score, many scores that we use in medicine to classify our patients and make a decision where to admit them or how to treat them. And recently, a group again from China has developed and validated clinical risk score on around 1,600 patients. And this is a really representative sample. So you have, you know, 74% of the patients did not have any comorbidities. So it's not a selected sample where you have only sick patients admitted. This is a sample of a large cohort representative of different spectrum of the illness. And based on this large cohort, they found these variables to be associated with the development of critical illness, X-ray abnormality, age, hemoptysis, dyspnea, unconsciousness, comorbidities, cancer history, neutrophil to lymphocyte count, LDH level, and bilirubin level. And you can plug in, they develop this prediction calculator. It's available on this website that I highlighted here. You can try it, and in fact, if any resident or fellow is interested, we can validate it in our cohort of COVID-19 patients. But basically, you plug in the numbers, and it will give you the total score and the probability that the patient will develop critical illness, and what if they are high risk or low risk. So this particular patients with these variables have a probability of 76% with a confidence interval of 68% and to 89%. So a common question that we always get asked, and, you know, we think about, is why certain patients develop severe disease while others have asymptomatic or mild infection. And this is a question that is being continuously studied. So, you know, any answer will show fault of a definitive answer. But what we know so far is, you know, there is a delayed or impaired type 1 and type 3 interferon response that check the virus and makes it under control. And we know from previous studies that older patients, diabetes, cancer, obesity, all these comorbidities are associated with a poor type 1 interferon response, and all are associated with chronic inflammation. So, you know, you're starting with a chronic inflammation status, and you add on it a blunted or diminished interferon response. So you end up with a severe disease. So how do you manage these patients who get hospitalized? So understanding the viral dynamics, the immune response is critical in choosing, again, as I said earlier, the important timing and patient population. So no one size fits all here. So although we have protocols, although we have guidelines, but you really need to understand the dynamics and the timeline so that you choose the appropriate treatment at the appropriate time and for the appropriate patient. So in the early phase of the infection, where you have viral replication before the patient have severe symptoms, this is where antiviral activity is important. Then once you enter into the pulmonary phase, you have pulmonary damage, whether with hypoxia or without hypoxia. Then here is the role of the immunomodulatory agents that we will be speaking about. And then you have the hyperinflammatory state that, again, with multi-system organ failure, ARDS, that we will be speaking about. So an illustration of the different phases of the viral replication and the targets for drug intervention is illustrated here. I will only discuss the drugs that we have so far available at KFMC. So we have chloroquine and the hydroxychloroquine. We have the protease inhibitors that we use for treating HIV. We have lopinavir, ritonavir. That affects inhibits the 3 chymotrypsin-like protease. Hydroxychloroquine affects the membrane fusion endocytosis of the virus. We have ribavirin and favipiravir. Unfortunately, we don't have remdesivir yet. So this acts on the RNA-dependent RNA polymerase. And we have the interleukin-6 inhibitors, mainly tocilizumab. So remember the slide that I've shown earlier. At day 7, usually this is when patients, after onset of symptoms, they start to have dyspnea, and this is where you want to start the immunomodulator. You don't want to start immunomodulators early and blunt the the interferon type 1 response, and you don't want to delay the antivirals late in the course of the disease where the virus has already reached its peak. So this is really very important. So what are the therapeutic classes? We have the antivirals and we have the immunomodulators. Among the antivirals, we have the convalescent plasma, we have favipiravir, we have the triple regimens, interferon, lopinavir, ritonavir, ribavirin, we have hydroxychloroquine and remdesivir. And then for the immunomodulators, we have the broad spectrum immunomodulator, the corticosteroids, and we have specific immunomodulators, the interleukin-6 inhibitors, interleukin-1 inhibitors, and JAK inhibitors, and many others. Now back to the basics. Remember the way we treat our patients is not always based on level 1 evidence or randomized trial. This is a slide that I always show when I talk about management of different diseases, where we a team at KFMC, we looked at all the IDSA guidelines published until 2010, and we reviewed 4,000 recommendations made by the Infectious Disease Society of America guidelines, and only 16% of these guidelines recommendations were based on level 1 evidence, which is randomized trials. 30% were based on level 2 evidence, observation studies, and 50% were based on either anecdotal experience or expert consensus. So 50% of the recommendations are based on low-level evidence. So this means that we can't wait for randomized trials to be completed to treat our patients. So we have to make some treatment decisions. This is opposed to the current IDSA guidelines for the COVID-19 patients management, which have taken a completely different approach. Their goal is to recruit patients into ongoing trials. So if you look now at the updated guidelines from the IDSA that were published yesterday, updated yesterday, you'll be surprised with these recommendations, but their goal is to recruit patients to ongoing trials to close all knowledge gaps. And I agree with this approach if you have an infrastructure to conduct randomized trial. For example, I've asked my colleagues at the Mayo Clinic how they're treating patients. Do they have a protocol? They said, we don't have protocol for treating patients. Everybody receives supportive care. And now with the new trial about remdesivir is offered remdesivir. Anything else, the patient has the choice to be enrolled in a randomized trial. So nothing is given outside the context of a clinical trial to these patients. So the IDSA guidelines, they recommend, the only recommendation they make for patients with COVID is remdesivir for severe and critical illness. And they said if there is drug shortage, then you would only give it to severe patients, not for critical patients. The duration is 5 days for severe illness and critical illness is 10 days, but this is the only recommendation they give. They recommend for corticosteroids and ARDS in the context of clinical trial. They recommend these drugs only to be used in the context of clinical trial: convalescent plasma, hydroxychloroquine, combination with azithromycin, lopinavir, ritonavir, or tocilizumab. And they recommend against the use of corticosteroids for hospitalized patients, and we'll talk about this. This was updated yesterday morning, our time. So we start with convalescent plasma. Convalescent plasma is not a new treatment modality. It's been used in previous pandemics in 1918 with the influenza, in 1934 with the measles, 1946 with the mumps, and this is the plasma which contains clotting factors. It's obtained by plasmapheresis. It's separated from cells, separates the cells from the liquid, and it contains a specific virus immunoglobulin that usually develops late in the course of the illness and early convalescent period. It contains both IgM and IgG. It has a long half-life, and it contains neutralizing antibodies that will attack the virus, and then macrophages will eliminate this complex, or it has non-neutralizing antibody, which mediates antiviral function through a different modalities. So early on in the course of this pandemic, multiple reports came out about successful treatment of convalescent plasma to treat COVID-19 appeared in JAMA and PNAS and CHEST. But the most important trial was published recently in JAMA. It's a small trial, again, from China. It was stopped early because, at the end of the pandemic in Wuhan, they didn't have more patients to recruit. So they stopped the trial after recruiting 103 patients. 52 of them were randomized to receive convalescent plasma, and 51 were randomized to receive standard of care. And this is the distribution and characteristic of the patient. The study was well balanced between the treatment and control arm. But what's interesting here is that the majority of patients were recruited to the trial after 14 days of symptom onset. And remember, convalescent plasma is an antiviral treatment modality. So in the majority, unfortunately, in this trial, it was started very late. 93% and 89% of patients, they were given convalescent plasma after 14 days of treatment onset. So the trial results was negative. There was no difference in time to clinical improvement between the two. The only difference was, as expected, there was faster virologic recovery at 24 hours, 48 hours, and 72 hours, between 4 to 11-fold between patients who were given convalescent plasma. So there was quicker viral clearance. But what's interesting about the study, they did a subgroup analysis looking at which patients could have benefit from convalescent plasma despite the late enrollment. And in patients who have severe disease, who are hypoxic on oxygen, but they're not intubated yet, they benefit from convalescent plasma. There was a significant improvement in clinical improvement, time to clinical improvement in patients given convalescent plasma as opposed to controls, and there was no benefit in patients who are already intubated or have life-threatening disease. Unfortunately, this trial didn't have the final answer about our question, probably because the enrollment was late, but it's reassuring that patients who have severe disease would benefit from this transfusion. Now, people ask about, what's the safety of this treatment modality? And again, this week, a large cohort, the largest cohort of convalescent plasma experience was published from the Mayo Clinic as the coordinating center for the US convalescent plasma protocol. They enrolled 20,000 patients so far. And they had patients across different disease severity, as you can see from this table. 70% of them had severe or life-threatening illness, and 34% of patients were intubated. The interesting part is here, or the important part is here. So the incidence of mortality after convalescent plasma transfusion is 6 per 10,000. So for every 10,000 transfusion, there would be 6 patients who die from a reaction from this transfusion within an hour that is thought to be related to the transfusion. The incidence of TRALI was 1 per 1,000. So for every 1,000, one patient would develop TRALI. And the risk of cardiac event is 37 per 1,000, which could be related again to convalescent plasma. So it's a minimal risk, but it's not zero. Now we'll shift gear to the second antiviral agent, the hydroxychloroquine, that has received a lot of media coverage. National stockpiles, even presidents have talked about it and preached for using it other than scientists. And a recent review looked at, where could hydroxychloroquine work to stop viral replication. And you can see from this figure, at least nine different phases of viral replication, or even 11, in fact, the virus could affect the viral replication or the immune reaction. So it's thought to be, very helpful in the treatment of the disease. Unfortunately, this has not turned out to be the case. In a recent special article or a practice paper from the American College of Physicians of a living systematic review, that found out among 10 studies looking at hydroxychloroquine versus comparators in the treatment of COVID-19, there was insufficient evidence about benefits and harms. And we're doing, actually, we're finishing a systematic review about the topic, about the efficacy of hydroxychloroquine that hopefully we'll be sharing soon. And we also have looked at the safety data that I'll share with you shortly. So we looked as a group privileged to have worked with all these people that have contributed to this important work. We looked specifically at the cardiac toxicity of chloroquine or hydroxychloroquine in COVID-19 patients. That was published on June 20th on the preprint server. We've reviewed more than 1,000 papers, and we've included 19 total single-arm analysis to look at the risk of torsade de pointe or ventricular tachycardia or cardiac arrest in those taking hydroxychloroquine. And we found out that the pooled estimate of this cardiac toxicity is 3 per thousand. So 3 per thousand on average, but it ranges anywhere from 0.01 to 19 per thousand. Depends on the underlying illness and severity of illness, concomitant medications, and age of the patient. If you compare this estimate to another drug that has been withdrawn from the market because of torsade de pointe cisapride that we used to use a decade ago for GI motility, and GE reflux was withdrawn from the market because of the incidence of 1 per 100,000 torsade de pointe. We also looked at, the incidence of prolongation, discontinuation of the medication due to prolonged QT or other arrhythmia. It was 5%, so a large number of patients. The incidence of QTC more than 500 or QTC delta more than 60, both an indicator that the patient may be at risk of torsade de pointe, was 9%, again high. And on June 4, the recovery trial investigator issued a press release that, we've looked at our patients enrolled in the hydroxychloroquine arm so far, 1,500 patients, compared them to 3,000 patients and the usual care, and we found no difference in mortality and no difference in other outcomes, hospital stay or other outcomes. So this has put a big question mark, the lack of efficacy, the cardiac toxicity, and the use of hydroxychloroquine. And, we were not surprised that this week the WHO have stopped the hydroxychloroquine arm of the Solidarity trial. The NIH has stopped their trial also for outpatients on hydroxychloroquine, and Novartis have stopped all their trials of hydroxychloroquine. It seems that's the end of the road for hydroxychloroquine, and we're going to have to wait for the studies that were completed already to be published and look at the data more carefully. Now, we move to a second antiviral agent that we're using now here at KFMC. It's manufactured in Saudi Arabia also, favipiravir. As I've alluded earlier, favipiravir and ribavirin, remdesivir, they act on the RNA-dependent RNA polymerase. And despite being used in Japan, in China, in Russia, in Turkey, unfortunately, not much data have been published about this medication. And there are now mega trials going on in India and Russia. We don't have the results yet, but so far, from what we know from published studies, there is only non-clinical data that suggests there is rapid viral clearance at day 7 in patients who took favipiravir as opposed to others. The drug is usually safe. It can cause a lot of GI side effects, and you have to pay attention to drug interactions. It can cause also increase in uric acid. We don't know the clinical significance of this mild elevation in uric acid. But so far, we don't have robust clinical data to support its use universally, although we are using it given the, its mechanism of action and good safety profile. Now we move to the triple antiviral regimen, which is the combination of subcutaneous interferon beta-1b, lopinavir, ritonavir, and ribavirin for the treatment of patients with COVID-19. And, people were expecting that it's not going to work because, data from the MERS-CoV medical trial or observational study data that, this was not an effective strategy to use interferon. But, SARS-CoV-2 is different than MERS. MERS viral load peaks late in the disease. SARS-CoV-2 peaks early in disease similar to influenza. So this group of investigators from Hong Kong, they did a phase 2 trial where they enrolled 127 patients. 86 of them were assigned to the treatment arm and 41 assigned to the control arm. This is 2-to-1 trial, and the reason for assigning 2 patients to treatment arm and 1 patient to the placebo arm is not to deprive patients from a potential beneficial medication. So when you have medication that you think is beneficial, you can use a 2-to-1 treatment assignment. So the majority of patients here had mild infection, okay? So only 15% were requiring oxygen. So the majority had mild to moderate infection, but 75% of them on average had X-ray abnormality or viral pneumonia. So this is not a critical illness cohort or severe illness cohort, but rather mild to moderate infection cohort. And the important finding, it's a phase 2 trial, but there was a great reduction in the duration of hospital stay from 14.5% in the control group to 14.5 days versus 9 days. There was also quicker virological recovery, and the patient become less infectious very shortly after treatment. And what's interesting about this trial is, again, the subgroup analysis looking at the treatment effect in relation to the initiation after symptom onset. So those patients who were given the interferon regimen before 7 days after treatment onset had the significant benefit, whereas those who were given the treatment after 7 days of treatment onset had no benefit of this intervention. Again, this is consistent with our understanding of the viral dynamics, where viral peak and viral activity happens early in the disease. So this is with the time, the first week after, of symptom onset, where you want to act early and give the patient antiviral treatment. There was no difference in side effects. We all know that, ribavirin and interferon and lopinavir, ritonavir have GI side effect. Watch for drug interactions. So ribavirin and lopinavir is cytochrome P450 inhibitors, and also it can lead to QT prolongation. So please make sure you check drug interactions when you use this regimen. Also, you don't want to give interferon to any patients beyond 1 week of symptom onset, because remember, you will induce more inflammatory reaction and inflammatory cytokine release syndrome. So you don't want to give it beyond 7 days of the symptom onset. Now we move to the immunomodulatory. We've talked about the antiviral treatment. Now we're going to be talking about the immunomodulatory. We're going to start with the dexamethasone that has hit the news all over as the savior or the wonder drug that's going to save the humanity from this pandemic. And I think it was given much more attention than it should be. So let's look at the details. So dexamethasone or prednisolone, all these glucocorticoids are broad spectrum immunomodulators. They act on multiple pathways, so they're non-specific and they can suppress the healthy and the important and non-important inflammatory processes. So it's a broad spectrum. What we know about corticosteroids from the pneumonia literature, this is a meta-analysis that was published last year looking at trials, the small trials of steroids and community-acquired pneumonia, and it seemed, in these trials, there was a survival benefit in patients given steroids versus controls. And on June 16, the recovery trial investigators surprised us again by releasing a press release on June 16, saying that we found that patients who were given dexamethasone did much better than patients who were given controls. And only yesterday they published their findings on the Preprint Server Med Archive, and I'll be sharing this with you. So they enrolled 6,400 patients, and 2,000 of them received the dexamethasone 6 milligram for 10 days versus the usual care alone. And this is the primary outcome, 28-day mortality, and there was significant decrease in mortality, around 17% decrease in mortality in patients who received dexamethasone as opposed to those who received the supportive care only. And again, there was 11% increase in discharge from the hospital at 28 days as opposed to control group. When they looked at the subgroup analysis of which patient benefited most from dexamethasone, it was the patient group that was on mechanical ventilator. As you can see here, the patient survival on dexamethasone and the mechanically ventilated patient was much better with dexamethasone as opposed to the usual of care. And the number needed to treat was 8. So you have to treat 8 patients with dexamethasone to save 1 life in those who are mechanically ventilated. And those who are on oxygen but not yet ventilated, number need to treat 25. You need to treat 25 patients on oxygen to save 1 life. But very importantly, the subgroup analysis that was published yesterday on the supplement of this trial looked at also more subgroups. So in those who were not on oxygen, look at this. So in those who were not on oxygen, the relative risk was 1.31. So around 30% increase in mortality in the subgroup of patients who were given steroids who were not on oxygen therapy. So there could be potential harm. Remember, again, you don't want to start immunosuppressant or immunomodulator drug early on the disease. And usually, as we said earlier, oxygen dependency or shortness of breath won't happen usually before 7 days where the viral replication is about. So you don't want to start immunosuppression early on, suppress the type 1 interferon response and make the virus replicate more. So this could explain why there is a higher mortality in this non-oxygen receiving group. We will have to wait for the full trial to be published, but this again is concordant with our understanding of the viral dynamics. What's also interesting, again, that was published in the supplement, the subgroup analysis of onset of symptoms duration. So again, in those who were given steroids, if their symptoms were less than 7 days, they won't benefit from it. And for those who were given it beyond 7 days, this is where you need immunomodulator, they benefit from it. Okay, so one size does not fit all. So it's not as the media explained to everyone that everyone with COVID should be on dexamethasone. This is concordant with the graph I've shown earlier. The virus peaks very early on and then it starts to decline by day 7. So if steroids is used earlier than day 7, it may lead to harm. If it's used after day 7, it may lead to benefit. There are multiple, observation studies. We're in the process of doing a systematic review, in fact, at KFMC, and this is only an illustration of the heterogeneity of the finding. In some studies, there was higher mortality or ICU admission. Other, there was benefit. So we'll see when we finish the systematic review, to see if observational data is concordant with the recovery trial. So corticosteroids, are not without risk. So, sometimes we think the benefits are overstated and the risks are understated. If you look at the influenza literature, this is a meta-analysis of observational data for the influenza patient, severe influenza who received, for influenza patient who received corticosteroid, there was higher association with mortality as opposed to no corticosteroids. So our protocol at KFMC is concordant with the recovery trial subgroup analysis. So we've been recommending it ahead of the disclosure of the recovery trial to patients who have severe disease and have new supplemental oxygen requirement of more than 4 liters or have escalating oxygen requirement from baseline. So we don't give it to everybody. And we use it also for patients who are ventilated and have ARDS. So the second immunomodulatory agent is tocilizumab. It has again received a lot of media attention, specifically on April 27. Roche announced that, on the press release without any data, that the Corimmuno-Toci trial, which enrolled around 129 patients, 65 to receive tocilizumab and 64 to receive the usual care. And they said, we looked at the primary efficacy endpoint, the combination of ventilation need or death at 14 days, it was significantly reduced with tocilizumab. That was on April 27. Today we're June 24 and the data hasn't been released yet, neither as a preprint or peer-reviewed publication. So we don't know yet the truth behind this press release. We have the largest cohort of patients who received tocilizumab from Spain. It's a multi-center cohort study. 260 patients received tocilizumab, 969 were the control group, and an adjusted analysis looking at mortality as an outcome. The adjusted hazard ratio for death was lower for patients who received tocilizumab and had high CRP, as opposed to those who received tocilizumab but had CRP less than 150. So the benefit was pronounced in patients who were on tocilizumab and had high inflammatory marker of CRP of more than 150. So this is the data that we know of tocilizumab. So far, we're awaiting ongoing trials. So our protocol here at KFMC, we use patients who have COVID pneumonia, they have rapidly progressive respiratory symptoms, and they have no known bacterial or fungal infection. This is very important because you don't want to make this co-infection progress. And they have at least two of the following lab markers, either a ferritin more than 300 or doubling over 24 hours, LDH more than 250, D-dimer more than 1, or CRP more than 70. And usually these patients have failed steroid initially before receiving tocilizumab. A word of caution about tocilizumab: it's a very long acting agent, have a long half-life, can be from 6 days to 18 days at high concentration. It is associated with the secondary bacterial and fungal infection. It does increase the risk of TB reactivation or HPV reactivation. So it's not a drug without side effects. And you use it with caution in patients who have neutropenia, thrombocytopenia. It can few cases of liver necrosis have been reported so far. So it's not a completely safe drug to use. So based on this discussion, now you can understand, why we put all these variables in our COVID-19 assessment form. So the age is critical. Duration of symptoms is extremely important in our decision-making process. The risk factors for severity, the progress of the patient, as if, you've seen, we classify patient mild, moderate, severe, critical, and whether the patient is improving or worsening. So this will affect our decision-making process. And all these variables that I've talked about are really important to monitor for inflammatory signs or cytokine release or for drug toxicity. And we keep an eye on all of this. At the same time, we focus too much on the virus and we forgot the other organ and the lungs, and forgot other organs in the body. So please don't forget, the heart, the kidneys. So in patients, so we're going to be talking lastly about statins and ACE inhibitors. Because ACE inhibitors upregulate the ACE2 receptor on cells. So initially, at the start of the pandemic, people were concerned that ACE inhibitors or angiotensin receptor blocker may upregulate the ACE receptor and increase the chance that the patient would get infected with SARS-CoV-2, or that the patient who developed COVID-19 disease would have a poor outcome. We've looked at both questions and our data are published. Again, I'm delighted that I've been part of this group that looked at this, and we found that there was no evidence of either increased risk of mortality or increased risk of infection with SARS-CoV-2 in patients who are on ACE inhibitor in ARM and COVID. So the heart is so important. So when patients deteriorate, please consider cardiac events, because the virus can affect the myocytes, can cause myocarditis. It can affect the vessels with endotheliitis, and it can cause arrhythmias and supply-demand mismatch and acute coronary syndrome. Multiple autopsy reports have been published in Lancet and the New England Journal of Medicine and other journals describing endotheliitis in different organ systems, where you have endothelial cells in the lungs, in the intestines, in the brain, and elsewhere. At the same time, many patients admitted with COVID-19 will develop myocardial injury, as you can see from these series published in Lancet, JAMA, and JAMA Cardiology, where the incidence of myocardial injury in patients admitted with COVID ranges anywhere from 7% to 19%. So it's not a small risk. So in addition, many of the patients with COVID-19 will develop cardiac arrhythmia. Again, this is a recent study published last week looking at patients admitted with COVID-19 in the ICU and outside the ICU. And among 79 ICU patients, you can see there were 8 cardiac, non-shockable cardiac arrest, multiple AFib, bradyarrhythmias, and non-sustained VTAC. This was lower in patients outside the ICU. So the severity of illness was an independent marker of cardiac arrest and arrhythmias. So remember, please, the heart. Remember drug toxicities, drug interactions when you give medications, and acute coronary syndromes and arrhythmias. And patients who have cardiac arrest, they have very high chance of dying and not being resuscitated. So our recommendation, or concordant with the Cardiac Society recommendation, is in patients admitted with COVID-19, if they are taking ACE inhibitors or ARB or statins prior to their disease, you have to continue these unless there is a clear contraindication, such as rhabdomyolysis or hepatitis or acute kidney injury. And if a patient is not on statins and he has a good indication to start statins, such as a valid primary prevention indication or secondary cardiovascular prevention indication, or diabetes or hypercholesteremia, which is untreated, we suggest to start lipophilic statins such as atorvastatin, 40 milligram daily, based on our understanding. This is a paper that's under review for our group about statin. Statins have multiple mechanism to suppress viral activities across different phases of the viral replication. It has also multiple immunomodulatory effect that could suppress cytokine storm. And hopefully, we will be doing a trial about the use of statins in COVID-19 patients. So as you can see from this presentation, that one size does not fit all. Each patient has to be treated differently based on the symptom duration, inflammatory status, the organ damage, medication that they're taking, drug interactions. But now I hope you have a clear understanding of our approach to treating COVID-19 disease. By this, I will end my presentation. Thank you so much. Hello? Now